Despite being practiced for more than 40 years, the technique of Ercp for the treatment of bile duct stones has not been standardized. Therefore, the procedure can be challenging and protracted. In this masterclass series, we present the Orlando protocol that was prospectively validated in 409 consecutive patients who presented for an Ercp with common bile duct stones. By adopting this protocol, we were able to achieve single-session ductal clearance in greater than 99% of patients. The majority of stones in the bile duct can be extracted at Ercp with standard maneuvers such as biliary sphincterotomy and balloon extraction, and these standard maneuvers will be described in this video. The bile duct is first successfully cannulated, and the cladiogram revealed a free-floating stone in the proximal bile duct. A biliary sphincterotomy was then performed. The tip of the sphincterome is inserted inside the bile duct. The sphincterome is then flexed slightly, and a sphincterotomy is performed in the 11 o'clock orientation up to the junction between the major papilla and the duodenal fold. The stone was then extracted using the standard approach using a stone retrieval balloon. However, some stones can be challenging. While every clinical scenario cannot be anticipated, following evidence-based principles can help with the management of the majority of difficult bile duct stones. In this patient, a cladiogram revealed several large bile duct stones. Taking this patient as an example, we will now go through the protocol-based management of bile duct stones. When stones are seen at cladiogram, the most important question that each endoscopist must ask is whether advanced endoscopy techniques are required, namely, the need for balloon sphincteroplasty and the need for lithotripsy. The importance of these questions have been addressed in a prior randomized trial by our group, and a protocol-based approach to the management of bile duct stones has been developed. A balloon sphincteroplasty must be performed when the tapered bile duct is seen, which is defined as size of the distal bile duct 1 cm above the ampullary orifice, being less than 2/3 of the extrahepatic bile duct in its largest diameter. Lithotripsy may be needed based on the stone-duct ratio, whereby the size of the largest stone exceeds the size of the bile duct distal to the stone. If these two questions can be thoughtfully considered prior to embarking on an intervention, then Ercp becomes less complex and more efficient. The size of the duodenoscope is first measured to be the reference standard. Subsequently, the size of the largest stone and size of the duct distal to the stone are measured to calculate the stone-duct ratio. Then the size of the extrahepatic duct in its largest dimension and the size of the duct 1 cm above the ampullary orifice is estimated to determine whether the distal duct is tapered or not. In this particular case, the distal duct was not tapered and the stone-duct ratio was less than 1, and hence a determination was made to proceed with an Ercp adopting the standard technique. After performing a sphincterotomy to the duct-duodenal junction, stone extraction was commenced. Stone extraction is then performed and must begin with the distalmost stone. The technique of stone extraction involves positioning the fully inflated stone retrieval balloon above the stone. The big wheel of the duodenoscope must be fully deflected down, and then the duodenoscope must be torqued clockwise and then gently advanced inwards in the axis of the bile duct. The objective is not to pull the stone out, but rather to have the balloon and the duodenoscope extract the stone using its own gravity. This prevents balloon tears and minimizes the possibility of ductal perforation. In this patient who presented with abdominal pain and elevated liver tests, the cladiogram reveals a distal bile duct that is narrowed. The extrahepatic duct and its widest area is now measured. As the distal bile duct above the ampullary orifice measures less than 2/3 of the widest portion of the extrahepatic bile duct diameter, this patient is deemed to have a tapered bile duct. Also, the stones are large in size, and are unlikely to be extracted successfully through the tapered distal duct using the standard techniques. Therefore, a maximal biliary sphincterotomy is undertaken and a balloon sphincteroplasty is performed. The size of the balloon should not exceed the maximum size of the bile duct. Also, prior to balloon dilation, it is important to dislodge any stones in the distal bile duct more proximally, so as to avoid inadvertent ductal perforation by compressing the stone against the duct wall. Once balloon sphincteroplasty is completed, the large stone can be extracted successfully using a stone retrieval balloon by downward deflection of the large knob of the scope and then torquing the scope clockwise and advancing the scope inwards in the axis of the bile duct, thereby allowing the gravity of the scope to extract the stone. This patient was referred for extraction of bile duct stones after failed ductal clearance at an outside facility. As evident on this cholangiogram, there was only a mild stone-to-duct mismatch in this patient. In this situation, mechanical lithotripsy is possible only when the catheter sheath can be easily passed to the proximal bile duct and the basket opened adequately for stone capture. As the patient also had a tapered distal duct, balloon sphincteroplasty was performed. The mechanical lithotripsy basket was then introduced into the bile duct and then opened proximal to the stones. A gentle shaking motion of the basket allows the stones to be captured inside the basket, which is then closed to fragment the stones. The stone fragments can then be easily removed, either using the basket or a stone retrieval balloon. The final cholangiogram shows complete ductal clearance. This patient underwent an Ercp for bile duct stones. The bile duct was first cannulated, and the cholangiogram revealed multiple impacted stones with duct to stone mismatch and a tapered distal bile duct. After performing a biliary sphincterotomy, balloon sphincteroplasty of the distal bile duct was performed first due to the tapered bile duct, and then stone removal was attempted using a basket. However, the basket, although able to be passed proximally, cannot be opened adequately to capture the stone. This is due to the large stone size impinging on the catheter and precluding the basket from opening completely. These patients typically have a stone-to-duct ratio exceeding 1 and will almost always require cholangioskopy-guided laser or electrohydraulic lithotripsy as the first step for stone fragmentation. Subsequently, this patient underwent single-operator cholangioskopy-guided electrohydraulic lithotripsy of the large bile duct stones. Once the stones have been adequately fragmented, the stone fragments can be removed using a stone retrieval balloon or baskets. By using a cut-off value of 1 versus greater than 1, we can determine if mechanical lithotripsy or single-operator cholangioskopy-guided lithotripsy would be more appropriate for the management of bile duct stones in patients with stone-to-duct mismatch. By adopting this protocol, we were able to manage all patients with bile duct stones without the need for a crossover. When successful stone extraction cannot be achieved despite using advanced techniques, a 10 French biliary stent is placed for biliary decompression and a follow-up Ercp is performed for reattempt at stone extraction. In this patient with a huge bile duct stone located proximal to a malignant biliary stricture, single-operator cholangioskopy-guided laser lithotripsy was performed. However, due to the large size of the stone, complete stone removal could not be performed, and a biliary stent was placed. While certain situations may be unique, we have presented a simple evidence-based protocol that can be adopted in everyday clinical practice to achieve single-session ductal clearance in greater than 99% of patients.
If you want to learn evidence-based practices and know more about state-of-the-art endoscopy technologies, please attend Florida Live Endoscopy from August 22nd to 24th, 2024 in Orlando, Florida,
where advanced interventions will be performed by internationally reputed faculty from around the world. Please join us at Florida Live, where the magic of endoscopy begins.